Hi, everyone. Thank you for joining us today for an important conversation in which expert panelists will help us understand the impact of the COVID-19 pandemic on one of the most vulnerable populations to this situation, the elderly and those who live and work in nursing homes. I have the good fortune of knowing many of you, but for those of you who are new to us, I am Donna McKay, the Executive Director of Physicians for Human Rights, PHR. Today's conversation marks the 20th in PHR's webinar series, which since we launched in March, has been examining the implications of the pandemic through the crucial lens that combines health and human rights. We're bringing together healthcare workers, scientists, advocates representing NGOs, and voices from the front lines on a broad range of topics. And since the pandemic began, PHR's membership has soared, which is an indication to us that people are looking to PHR for a science-based analysis and approaches to guide response to this massive public health crisis. We have nearly 500 people live with us today to hear from expert panelists as they discuss the disproportionate and devastating effects of COVID-19 on elderly and nursing home populations, including the healthcare workers who care for these populations. And as cases continue to surge and a vaccine is yet to be developed, COVID-19 has taken its toll on this population, exposing really missed opportunities in prevention and treatment and further exacerbating the gap in equity individuals with disabilities face. 30 years ago, the American with Disabilities Act, the ADA, was signed into law in order to end unlawful discrimination against individuals with disabilities. And it was intended to ensure that individuals living with disabilities would live dignified lives, integrated in our communities with access to the same care and resources. And these standards should apply to those who live in nursing homes and assisted living facilities too. So while this population comprises less than 1% of the population, it comprises 50% of all COVID-19 related cases of deaths in the US. And the disparities are not unique to the US. Nursing home staff are risking their lives as they try to protect residents from COVID-19. The Centers for Medicare and Medicaid Services reports the work is now the most dangerous job in America. I'd like to welcome our expert panel today who will discuss the next steps needed to reduce risk and protect basic human rights for elderly populations. We're so fortunate to have the opportunity to hear from people who have dedicated their careers to improving the quality of life for older Americans through health, science, quality of care, and research. So I'd like to now introduce today's moderator, Dr. Joanne Lynn, one of the first hospice physicians in the US and an early developer of palliative care. She spent decades working with hospice, nursing homes, and home care patients and has led public health, quality improvement, and research endeavors. Joanne is a policy analyst at the Program to Improve Eldercare at the Center for Appropriate Care at Altarum, a nonprofit research organization that develops solutions to advance health among vulnerable populations. And she is a health and aging policy fellow working on long-term care financing and COVID-19 issues. Joanne, thank you so much for being with us today, and I will turn it over to you.
Thank you so much. It's really wonderful that PHR has taken up this issue. I'm delighted to have three remarkable colleagues in my panel, and I'll introduce them as they give their introductory remarks. As you said, COVID-19 has been especially harmful to elders, and particularly to people living in nursing homes. The combination of serious illnesses with the lack of reserve in many body systems and the decline of effective immunity with age, living in close quarters with inadequate supplies and inadequate staff have combined to make it very difficult for nursing homes to evade contamination, especially when the community spread is high. The regulations and guidance to protect elders living in nursing homes have incredibly ignored the preferences of the residents and their families completely. The likelihood of immunity in recovered residents and staff has not made it into any guidance, and even the lack of available testing and PPE has been just shocking. This amounts to an offense to residents' dignities and rights, as well as risking their lives. I would say that the residents in nursing homes especially are being treated like cattle needing protection and not like human beings facing a very serious set of circumstances. The testing of immunizations seems to be avoiding nursing home residents. Nursing homes have been attractive investments for investor-owned facilities, but the track record of staffing has been really miserable. The return on investment for the investors has been good, but the staffing rate in the average nursing home is still not meeting even the minimalist CMS standards. And yet most of us here today will need long-term care. We'll need it at home. We may need a facility. Most of us will need an average of 2 years of personal care at the end of life. And we will, if we keep doing it as we have done, we will not have made plans. And then we further complicate things by inadequately funding Social Security and Medicare and having now a severely compromised economy. There's a lot of shortcomings, but there are strategies to address them if only we care enough to implement them. And that's what's missing, is the will to actually tackle these issues. You have to be thinking 10, 20, 30 years out, not just the next election. And finding leadership that will think in generational terms has been very limiting. But here we have a team of panelists to illuminate the challenges and the potential improvements. And let me start with Sharon Brangman. Sharon is a physician, a distinguished service professor, and inaugural chair of the Department of Geriatrics at SUNY Upstate in Syracuse. She's director of the Center for Excellence for Alzheimer's Disease and of the NAPI Longevity Institute. Sharon, go ahead and say your opening thoughts.
Hi, thank you for inviting me. This is a subject very close to what I do every day. I am a clinician, I'm a geriatrician, I take care of patients. And from the beginning, those of us in geriatrics have been horrified with the way the pandemic and our responses rolled out. If you recall, it started in Kirkland, Washington in a nursing home. And despite this, we were not prepared to help nursing home residents protect themselves and their staff from this disease. So we saw with horror what was happening in this nursing home, but we still did not have adequate PPE or testing. The focus was on the hospitals, and I think the hospital care was being prioritized over nursing home care. And the whole process really has kind of highlighted the issues of ageism and racism in our country. So if you remember, the initial conversations were about how old people were expendable. There were politicians who said, well, old people wouldn't mind dying to save the economy for their grandchildren. You know, if you have a chronic disease, you're gonna die anyway. And my patients heard this and they have been terrified. The other thing is that we lump everyone over the age of 65 into one huge bucket. And that ignores the heterogeneity, both physically and cognitively with older people. So I have patients in their upper 80s who are still active members of their community and are contributors in many different ways. And I have people in their 60s who have advanced dementia and need care. So we cannot look at someone's age and make blanket statements about what they do or don't need without looking at the individual. So my whole career in geriatrics has been looking at what individual patients need and not just based on their age. So if we look at the big picture, I think our lack of respect and caring for older adults was very prominent from the beginning. That's why when it became clear that older adults were disproportionately affected, we saw all these youngsters going on spring break. You know, they thought, well, what's the loss? I will be fine. And that helps to keep the virus alive. Then when we started to hear that there was higher rates of death among Black and brown people, we really saw a move to open up the economy. And so those messages have been very clear to my colleagues as well as to my patients. I also have patients who do not have COVID, but are what I call collateral damage in the time of COVID, because they depend on caretakers and connections with the outside world to help maintain their cognitive and functional status. So it's ironic that a disease that requires physical distancing for protection or prevention from this disease can actually make an older adult sicker. We know that social isolation is very deadly in older people. It's equivalent to smoking a pack of cigarettes a day. And it can increase your risk of dementia, depression, certain cancers. So we can't think of it as social distancing. We have to think of it as physical distancing while we're still helping people in the community maintain their social connections. I have patients that don't have internet. They still have landlines. They get confused with the menus on the phone, as we all do. You know, press 1 for this, press 2 for that, press 3 to hear the message again. They can't order groceries online without help. They don't understand the internet, or maybe they can't afford it. I have patients that have a flip phone that does really the bare minimum. So as we started to transition to home care and telehealth, we had to take this into consideration very quickly, because we had patients that we had to take care of, and we had to figure out the best way to do it. We also noticed that policies were made in very blanketed ways without looking at individual needs. So for example, in our hospital initially, we had a no visitor policy. And if you have a frail older adult with an acute illness that was not COVID related and they had to go to the hospital, they were admitted without any visitors. And so that caused a lot of destabilization of people, because when you're older and sick, you really need an advocate and you need a familiar face at your bedside. So without having family members at bedside, we saw a huge increase in agitation and delirium. The other issue was that there was a lot of confusion on the signs and symptoms of COVID in older adults. And so a lot of doctors were looking at temperature as a model. And we know in geriatrics that a lot of older adults do not mount a fever when they get sick. And we were missing some of the symptoms because actually a change in mental status, confusion, or delirium is often the first sign. And it takes extra clinical skills to help discern this when you have a patient who already has dementia or some cognitive impairment and they are baseline confused. Similarly, shortness of breath may not appear like it would in a younger patient, because many of my patients already have underlying heart disease or lung disease, so they may already be short of breath. So we weren't necessarily looking at the symptoms that are unique to older adults so that we could make an appropriate diagnosis. And then one of the biggest concerns has been those patients who are in institutionalized settings, whether it's assisted living or long-term care, where there was a complete shutdown, but we had frontline workers who did not have any idea if the patients they were taking care of were sick or not. These are essential workers who are usually women, often single women, making maybe $14.60 an hour with very complicated responsibilities, but getting very little public respect. So we didn't hear about them being considered heroes. They did not get PPE. There was no testing. It was really like working in a big unknown where you saw people were getting sick, you saw staff getting sick, and then nursing homes starting to get blamed for it. So we have a nursing home setting, which looks like a little hospital, where often the care is given in mass quantities to people without their ability to speak up and advocate for themselves. And at the same time, family members who are really essential to their care were not able to be at their bedside. So similar to not having visitors in the hospital, there were no visitors in the nursing home, and people with dementia didn't understand that. Then we have small practical issues, like how do you communicate with someone when you're dressed and you look like a spaceman and you have on a mask, and we have people who are hard of hearing and they have dementia and confusion and they do not know who you are. We've seen a huge increase in agitation and the request to sedate people when they really don't need sedation. They need reassurance and they need personal touch. But of course, these are all things that might spread the virus. So we've
Thanks.
had a very complicated rollout. I hope we have lessons learned, and I would like to have that discussion with my other colleagues on the panel on what we should do moving forward, because this virus is not going anywhere and we have to figure out how to coexist.
Thanks so much, Sharon. A real voice from the front lines. Let me turn now to H Hanson. Jenny is a remarkable and creative leader. She has a master's degree in nursing. She was the CEO of both the American Geriatric Society and the AARP. As a stakeholder to California's Department of Health and Human Services, she is developing the state's first ever master plan for aging. She serves on several healthcare and system boards related to care delivery, transformation, quality, and safety, as well as chronic care innovation and technology for older adults and long-term care financing. And Jenny serves on the National Veterans Administration Advisory Committee on Gerontology and Geriatrics, and on the Department of Health and Human Services, National Institutes of Health, National Advisory Council on Aging. Jenny, what would you add to our conversation at this point?
Well, I think Sharon has painted such a vivid picture, from the institutions to the individuals to the family. And so I appreciate, Sharon, the platform that you have provided. One of the things I was going to bring up in the course of my participation in this is the opportunity to serve on policy areas, as well as thinking about practical programs that are able to actually cross that threshold to really consider personhood during this time of a pandemic. So a few things that I'll bring up, and I know that Dr. Moore will give us a real close sense of looking at the environment, especially for nursing homes. One thing that wasn't brought up in the background first is the fact that I spent about 25 years with a program called Unlock in San Francisco. That was the predecessor to a program now called PACE, the Program of All-Inclusive Care to Elders. And this program now is a federal benefit under Medicare and a state benefit under Medicaid in 31 states. I'll bring up a little bit later, perhaps in the conversation, about some of the positive things that are feasible in this extraordinary period, that programs like PACE, because of the way they're designed to care for older individuals who actually are certified to be in nursing homes, but would like to remain in the community instead. Some of the flexibilities that were able to be mounted in some cases as short as 3 days, converting the operations of a program that serves elders in the community to actually changing a physical facility from what would be called a day program, a day hospital program, perhaps in the British context, to something that actually supported COVID-infected participant who had need to be sheltered in an environment and still have family involved. Because I think what Sharon brought up was the degree of isolation and loneliness in general during this whole pandemic. But then think about it at that period of time when the disease has taken hold, and it really is your last point in life, and the fact that family members couldn't be with you. So I will speak about that. And then the other area is to point out what Dr. Moore will convey is that when you have a community where the infection rate is lower, the opportunity not to have some of your institutions then be as infected as some of the high infection areas. And so here in California and in San Francisco, where I live, we have an amazing sized public institution nursing home that is 780 beds. You never hear about this in this day and age. This was one of the first sites that was reported, and you can imagine how, from an infection management perspective, this became a real highlighted effort to nowadays, the same number, more or less, of people who were originally infected, both staff and the residents, has contained and has not gone through a nursing home facility like this in the wildfire way that it is at risk for. And we have other nursing home facilities in this city who are similarly effective in controlling. And just this morning, I was listening to NPR, and it turns out they're about 40 miles south of us in Portola Valley from San Francisco. There is a cluster of nursing home facilities run by the Sequoias that also have managed to keep things under full control. So it's feasible when a community and a system and the leadership of these organizations, public as well as private, really lean forward into all the things that are necessary for best and safest care. So the question is this policy? Is it a program? Is it a training of staff? Yes to all three. These are things that are absolutely not necessary. It's one thing that we have in the state of California right now, the ability to do testing in nursing homes. So here's a policy, but the implementation is not fully materialized. So policy alone does not cover this. You have to have the alignment from policy to person to make sure these dots are connected in a way that is appropriate. And the last final comment I'll make is, it was alluded to that I am part of a group of people with the state to think about a master plan for aging. This was actually signed into action by our governor back June of 19. So this was pre-COVID, but the ability to work together with these nearly 40 stakeholders and the state, as well as foundations, to really develop a plan. You'll have that as a link. We had a report that came out just 2 days ago. And so I know PHR will put it on as an available piece of information that you can see what's happening, not only in California, but efforts throughout 4 states that have state plans and other states that have done this, because this does take long-range planning, collaboration, commitment, and follow through. Thank you.
Thanks, Jenny. And now Vince Moore is the Florence Pierce Grant Professor of Community Health at Brown University School of Public Health and a senior health scientist at the Providence VA Medical Center. He has quite a string of research and research awards, and primary focus has been on measuring nursing home quality and how state and federal policies affect the quality of care for vulnerable elderly nursing home residents. Vince, tell us what you've been up to.
Thank you very much, Joanne. So as Sharon mentioned, the first cases at the Kirkwood Nursing Home in Washington State, when that happened and that hit the news, I was in contact with folks from the National Institute on Aging, and they realized very quickly that this would be a spreading phenomenon, and we needed to have data. We needed to have data on where these cases were, particularly because it was going to affect people in nursing homes, and that the availability of information about those was quite limited. So building on relationships we've had for years with people in the nursing home world, we established a relationship with a large nursing home company, and basically have been for the past, since basically beginning of April, obtaining their data every night from downloads, clinical data from their electronic medical record, where we can look at and track the distribution and the spread of COVID and its determinants. So I thought I'd just give you a quick rundown of what we've learned in the 3 or 4 months since that's happened. You have to all put yourself in the position of what we knew in April as opposed to what we know now, and which was a lot less. So the first thing we looked at was, what are the determinants of a nursing home experiencing outbreaks? And it's really not what the nursing home is, it's where the nursing home is located. Nursing homes that are in counties that have very high prevalence of COVID have higher risk of the staff and the patients in the building becoming positive. And that's because it's a community acquired disease. It's transmitted person to person, and it's mostly transmitted not by people who are in a nursing home who don't tend to go anywhere, but by people who work in the nursing home but come from the outside and go back and forth every night. And that's because they live in more dense housing areas, population density, because by and large, the workers in nursing homes are poor, they're underpaid, and they often have to work multiple jobs, putting them at risk of transmission. And the people who get it transmitted to is the people in the nursing home. Secondly, so that the nursing home is a very susceptible community. It's just waiting for the spark of someone to enter who's infected and transmit. And while some nursing homes have been, as Jenny suggested, have been fortunate, they've been able to keep it out, it often requires a really great forethought and training well in advance in ways that are relatively unusual. Most nursing homes do not have infection control nurses, not like a hospital has a full-time epidemiologist worrying about these things. It's a job that's put on top of somebody else. Universal testing in nursing homes reveals, just like in the community, that about 60% of residents who actually test positive, who acquire the condition, are asymptomatic. They don't get sick, just like people don't get sick in the community. That's also happening in the nursing home. And what that means is that they're hidden. If you're just looking for symptoms, you can't find them. Among residents who do become positive, particularly those who are symptomatic, people with advanced cognitive and physical frailty, as well as advanced age, have very strong independent effects on the likelihood of dying, which is really important. It's the frailest of the frail who have the highest risk of dying. But what appears to be the case, this has not been published anywhere yet, it's relatively good news that it appears that the case fatality rate is declining. That is, in April, the 30-day mortality rate was a little bit over 20% for people who were diagnosed with symptoms at the time of positive testing. In May, that's about 11 or 12%, and in June, it looks like it's well under 10%. We're now looking very carefully at what are the causes of this shift in the mortality risk that's going on. It's a very important new finding that's going on and provides some level of hope and raises other questions, as Joanne has talked about it. At what point do we basically say, oh, let's open these places up because we can manage some of this risk in conjunction with the patients and their family members? But that's a complicated issue that actually we all have to talk about together. So the biggest challenge, and I'll close, is testing and the slowness of getting the results from the labs across the country. In hotspots where the rate of positive is high or increasing, nursing home staff should probably be tested every other day or perhaps every third day at the least. They should be paid enough so that they don't have to work in 3 different nursing homes or 2 different jobs where they're at increased risk of having an outbreak and bringing that outbreak back into the building. This issue of testing is critical. If we don't solve, as Jenny said, the implementation problems here, we're in trouble. If we can't increase the volume and the rate at which we get these tests done, by the time you wait 5, 7, 12 days, which is going on in Kansas City now, it's a useless test and it's basically not worth doing. So I'll stop there. Responses later.
I've been trying to get a test in Washington, D.C., and I can't get a guarantee in less than 10 days.
Right.
And in a nursing home outbreak, that would be worthless.
You need the testing that the NBA is getting.
Right.
Yeah, and the testing that the government sent out to the nursing homes turns out to be antigen testing, which is specifically not recommended for surveillance because in low probability situations, it's highly misleading. That's what happened to Governor DeWine. So now all these nursing homes have this testing equipment for a test that they should not be using. So, you know, we're just continuing to pile one more error on top of others. Jenny, talk a little about what sorts of situations should have elderly people using nursing homes. Should we be sending people to nursing homes to shorten hospitalizations? Should nursing homes be more culture change kinds of places with smaller units? What should our future look like?
Well, if we were talking ideally, the answer is yes. Many, even the short-term placements in nursing homes can be done otherwise. And part of it is having a system in place that rehabilitation, say, could be really still done in their homes. It's quite interesting because I also happen to be on the commission of MedPAC, the Medicare Payment Advisory Commission, some years ago. And we noticed that there were the distribution of even nursing home or post-acute settings that people could get rehab was not evenly distributed. So the natural question is, since it's not always available, how do other people who have surgeries and come out of the hospital, what do they do? Well, they have home health agencies, for example, that are well distributed, and they are able to provide some focus on doing this. So part of it is developing an implementation process of being able to take care of people. I think there will be aggregate places that people will need to live from sometimes permanently. So of course the design of these locations will need to be relooked at. And I know in Massachusetts, there's a mass design group that has actually drawn out diagrams as to what it would take to make this air movement, safety, communication, and socialization with the outside doable. So there is work in place, but needless to say, the cost of doing that for the facilities that exist now, when we talk about that thousands of nursing homes in the size, and people are oftentimes 4 to a room, not optimum. This really has huge cost issues, design issues, remodeling issues. And somebody has raised the question about, gee, oftentimes these facilities are actually real estate factors, different from the programmatic factors. So that is a financial issue of who runs nursing homes, both management side and the ownership of the property side, that really does raise some significant concerns as how we shift to using aggregate facilities like nursing homes or assisted living facilities in ways that are safer for people, promote some quality of life, as well as will be affordable.
I once worked in a nursing home that was a very good nursing home, and many people who came in would say, boy, if I had realized this was so much fun, I would not have resisted coming here for so long. There's activities and food shows up and I don't have to have my door locked. And, a good nursing home is a real pearl for the community. And we need more of them. we need to be able to be proud of them.
If I could add one final comment here in terms of options. Needless to say, I know the program of all-inclusive care to elders quite well. It has been fascinating to see that the rate of infection is like 1/10 that of the comparable population. So there are ways to do this, even with existing models of care. And I haven't been directly connected to PACE for over 15 years, but I am so proud of how that program has been able to be responsive and have the fluidity of changing even their architecture quickly, or really developing a whole telehealth way to both care for, communicate with older individuals and their families in a matter of literally 3 days. And so I know that happened here in California with a group operated under WellBe Health, and in Massachusetts under Fallon Health, So these are feasible options today, but it really needs a different construct of thinking.
Yeah. Vince, comment a little on what's happening with testing these 52 companies that are doing vaccine development? Are we going to know how well this is working for frail and ill elders?
So right now, to my knowledge, there are two phase 3 large clinical trials underway. One here in the U.S. is the Moderna vaccine, which phase 2 trials ended in mid-July. This is probably going to be a dual dose vaccine. They're recruiting 30,000 people from across the country. We've been in touch with them in terms of trying to find out what their strategies and policies are going to be regarding recruiting older people. They have tried to set an initial quota of about 20% of the people will be 65 and over, but all of the people who are their volunteers to date have to be able to go to the testing site. So they're working with various testing groups which have the capacity to do the recruitment, the intake, all of the blood work and the testing, and then the ongoing follow-up of those individuals who are recruited after random assignment to get the experimental control condition. The other drug that's...
So very disabled people are effectively cut out.
Right. So there are some places that have the ability, whether it's going to be done or not is quite separate, is to recruit people who live in assisted living, bring a van, a mobile testing site to that place, and then have the person come out to the van into those places. To date, I don't know how well that's moving. The complexities of doing this in a nursing home setting. I'm doing a trial right now, a prevention trial in a bunch of different nursing homes here in Rhode Island. It's very complicated to manage those things. So it will be very unlikely. And so the answer to your question is we will not know at the end of the Moderna trial, vaccine trial, whether this works in old, frail people at all. We hope that it works in people who are like healthcare workers who go to and care for people in nursing homes. So if they're vaccinated, then they cannot transmit to the patients. And if the family members can get vaccinated, then they can't transmit to the patients, or at least reducing the risk. That's the hope.
Yeah.
We already have a model where we know flu vaccines don't give perfect immunity to older adults, especially if they're frail. The whole concept of immunosenescence,
Right.
where as we get older, we just don't develop the antibodies to protect us. So we're going to have to be very cautious and see what happens. And as Vince says, if everyone around that patient gets vaccinated, that may be an indirect way of protecting the patient, similar to what we do with the flu shots.
Right.
Yeah.
So, that becomes a really key issue. For influenza, there are now specially designed high dose or flu vaccine or multiple dose or other adjuvants that are available that work better and give you longer protection for older people. But there's still lots of debate as to whether or not you need a booster for February after having it in September. And those trials and that study, those things need to be done. We don't have a clue what to do on COVID for that.
Yeah. The availability of supportive services is just very limited all across the country. So most communities have at least a 2 or 3 year wait for any supported housing. Many have effectively none available. Most cities have more than a 6-month wait for home delivered food. And yet I saw in the news last week that on the chopping block is the Older Americans Act to cut the federal support for these things. Talk a little about what are we thinking about trying to keep people going in their communities and any real opportunities for improvement in nursing homes.
Well, I'll jump into that. I think it is so short-sighted to think that if we're not going to have as many people going to nursing homes, that we could cut programs and services like that of the Older Americans Act, which is really geared for basic needs like meals, having, hunger is continued to be a big issue, and the ability to have information and coordinated care. These are the kind of programs this act covers right now. And we had a little skirmish in California ourselves, because when the budget came out, the latest budget with some of the reductions that were proposed, two programs that were sentinel as part of our community-based system included what we call adult day care, which is kind of a program that provides some supportive services, some clinical services, but people go home at night. And then also a coordinating program called, in our state, Multi-Services Senior Services Program. But what that does is does the coordination and helps people identify people who have been identified as needing some services, and that this program would provide some connection to services. This was on a chopping block, while at the same time we were saying we have to be careful not to enter people into nursing homes if it's possible. That was an oxymoron, but it takes advocacy. I must say, people in the state of California wrote, those of us who were part of the master plan on aging group, the 40 of us, we also had a chance to meet with state officials. And the idea that we wanted to promote one thing for the future, that is long-term services at home as a benefit, but then not to have services in the community. It doesn't make sense. So alignment of intent of policy and execution of services at the ground level are absolutely necessary.
Yeah, we've touched on a few of the questions that the participants have lodged. One is asking in a couple of ways, sort of who's out there advocating and what are they advocating? And I have to say with some sadness that most of the providers have been loudest in advocating for protection from liability, and really pushing state legislatures and the Congress to make sure that they are protected from liability claims for all of these deaths and illnesses. But what else? Who else do you see doing something important? And what else should we be doing? What should we be doing to make sure that in a few years the situation is quite different? It's very sad to see testimony Vince gave back in 1982 that advocated for the things we're still pushing for, and they're still not done. So is the COVID experience a chance to exercise some leverage and actually get some planning done? What do you think, Vince?
So I suppose if one looked at the past, one would not be terribly optimistic, particularly because the fiscal hit that every state in the country is going to take is significant. Revenues are down by a third or more in every state in the country. And that's going to have, because almost all states have to have a balanced budget, that will have a dramatic effect on next year's budget for all of these states. And even if the Congress makes up for some of it, it's still going to be a real deficit. To address the issues for long-term care, it is essential that we deal with the physical plant, because most of the physical plants for long stay nursing home care are quite outdated. They were built, 40, 30 plus years ago, multi-room, and that was under optimal conditions. And there's pretty good evidence to suggest to make smaller communities, that makes it more helpful.
So that's one thing we should be pushing for.
Well, there have been projects like the greenhouse and others that have been looking at making smaller scale, more home-like settings, no roommates, kitchens that have normal smells and are easily accessible, so that we are starting to humanize the long-term care setting instead of making it all medicalized and taking away individual voices as to what they really value.
Yeah. No,
Jenny, you want to say a little about expanding PACE?
Well, yes. it is a program that has grown slowly. What is purely so ironic, it was 1997 that the legislation first passed that made this program possible. But I would say the past 5 years have seen a growth for that. And I think this pandemic has revealed the opportunity to build on that chassis that it has created. I mean, the PACE chassis of all the coordinated care. We're talking about the most acute issue of the pandemic right now, but things like dental care and transportation, having your home fixed, the idea of both the greenhouses, which is brought up here that Sharon mentioned with the smaller sizes, but the ability, most people, and ARP did a survey that most people over 50 have this wish that they would rather stay at home. And so with the PACE program growing the way it is, hopefully it's one part of the portfolio of answers of supporting people to live in their own communities. But I think I want to pick up on a theme that Sharon brought up earlier, how crucial this is from a policy perspective and from a programmatic perspective. And Joanne, you said this too. We have to understand what matters to people. It's not just designing these top-down programs, but hearing the voice of what gives people personhood, what matters to them, what kind of food that they might eat, how much they want to go out or not go out. We have to understand that undergirding this is the human rights that is part of the name of this organization that's sponsoring the webinar, is that the right to have your voice and what you hope for and wish for really heard, not just having good drawing designs to say what a physical facility is. So it goes both ways.
Yeah. Someone has asked about testing and immunity. I've found it quite intriguing that not only have our federal guidelines not asked for anyone to talk to residents and families, but they also still do not acknowledge any possibility of immunity. And we have more than 10 million proven cases worldwide, and at this point, no second infections. So that would seem to be a pretty good database to allow a person who has been through it to be much more flexible at least for a few months. We don't know whether it'll endure for a year, but at least for a few months they could hug their daughter. And we haven't really dealt with that. This person's asking about cellular versus antibody immunity, and I think that gets a little deep. But basically it's that antibodies we can test and cellular immunity we can't test very well. So we're going for what we can do. But the idea of immunity is terribly important, and yet all the guidance says things like surveillance, you have to do the entire facility. It doesn't say except for people who've already recovered, which is obvious. You shouldn't be testing people who've already recovered. So those are important things. I think that we really have to deal with the financing of long-term care that we face, especially with the setbacks in employment now. We face huge numbers of people coming into their older years without adequate financing of their own. There's effectively no long-term care insurance available, so we're really going to need to address that. Someone else raised the question in the chat or in the Q&A about the ownership of nursing homes. This is a very tangled web, and we really must get into the heart of it. Every legislator that I know of has some nursing home representative on speed dial, and they do not have a representative of the residents and their families. The nursing home and assisted living organizations have been very good at being involved in the political process, and there have not been very strong professional or consumer groups that have really been similarly engaged. So, as Jenny was just saying, and as Sharon said with regard to the greenhouses, we have some good models out there. We actually know a lot about what would support people well, but we are heading into a period of time when a doctor can write for a $50,000 drug with a sweep of their pen for a person who has no home and who can't get food. and certainly can't get someone to help them with a bed bath. And this is just such a whopping disproportion in what it is that we've invested in, that we really need a broad public dialogue. We need people to weigh in. We need people to stand up. We need people to push their organizations. What else would any of you add at this point? What could people do who are on this call?
Well, I think it is something that adult children notice when they're trying to find services for their mother or father, but often they're so consumed with it they don't have a voice. So what we really need are consistent voices. By the time you're a patient, you don't have that voice. And so what we need is a focused group of people that pay attention. Public health guidelines are very important, but if you don't have input from the people as to what they value, they are really not worth anything. So we have to figure out a way as a society, as a culture, to have inclusive voices from people who have different things that they value. We all are individuals. We have to come up with a collective way of making that work. Now, we have traditionally actively excluded or ignored certain parts of our society, and we can't really do that anymore. It's bringing us all down. So what we need is leadership in developing ways of getting all of our voices together, because really this is affecting all of us. And if we are all lucky enough to live into old age, we all want to do so with dignity and having our needs met. I, for one, do not like playing bingo. So I do not want to be in a nursing home where I have to play bingo all day. So I should have my needs met. And I think adult children get a hint of that. But by the time you are in your 80s and you need those services, you don't have the voice.
Yeah, we're coming to the close. Go ahead, Jenny, shortly.
Yeah, I'd say let us call for accountability and clarity from our elected officials, whether we're talking about at the local level, the state level, and now the national level. Ask these people who are running for office what their positions are relative to services and commitments and focus to older adults. And I know historically, I have not kept track of it, but AARP used to have a template of asking candidates what they would support relative to topics regarding aging. And maybe this is a vehicle of really calling for some visibility so that we flush out ageism, as well as the ability to say, what would you do as you plan for your policy and finance perspective as an elected leader?
Yeah, the chat has included a couple of the things that my group has put forward. We have 5 issue briefs that are well researched that enable people to ask pointed questions. And we're looking to crowdsource the issues that we could converge upon to improve nursing home care and care for people with serious chronic illnesses in old age. Someone asked about what makes Unlock and PACE a best practice. I'll take that on instead of giving it to Jenny. You have a comprehensive care plan for every person, and there's nothing that the PACE program can duck. They have to deal with whatever it is, whether it's a caregiver getting sick, whether it's a dog has fleas, whether it's COVID comes along and all of a sudden, people can't come to the day center for PACE. It's the bearing up of responsibility one by one for every single person coming into a PACE program. And again, there are so many outrages in this field, but why is it that I could not ever get into a PACE program because I'm not in Medicaid? We've got to make it possible for people who are not, utterly destitute to be in a comprehensive program that makes sense. And it could be a special needs plan. It can be PACE. It can be Commonwealth Care in Massachusetts. There are many such options, and they're serving a tiny proportion of the population. Most of us will confront chaos. Most of us will not have a coordinated support system. And with that, I think I have to turn it back to Donna McKay to wrap us up. This has been a wonderful chance to interchange with some of my favorite colleagues. And Donna, you can take it on to close us out.
This was brilliant. Thanks to all of you attending the conversation from the Zoom. We look forward to many more as we navigate the pandemic together. But really, thank you, especially to our panelists, Sharon and Vincent, Jenny, and our moderator, Joanne. It was an incredible conversation. Thank you so much for bringing your understanding of the issues to this conversation, and really importantly, for bringing us your recommendations for what our future should look like. In a brief 55-minute period, you managed to cover an enormous number of issues. We have an opportunity still to turn a corner in this situation of unnecessary deaths, and also how we live, how this population lives with COVID-19. And you gave us so many great ideas for policies and practices as it relates to the pandemic. But Joanne, you also asked, is the COVID experience an opportunity to get some reforms done that have not happened previously but should? And that was a great question. And I'd like to think so. I think we all would like to think so. Jenny said the pandemic's revealed the opportunity to build on the chassis of ideas that have been promoted for a long time. There are so many models out there that were mentioned today, so practical and helpful, including really importantly, giving voice to the elderly in all decisions. So we're so grateful for your leadership and your advocacy in the field. You are all amazing. And I think also today's webinar helped us to see so clearly how important the perspective of health professionals is, and it demonstrates exactly why health professionals should help guide our policies related to COVID. Policies driven by political agendas has put the lives at risk and should really have no place during the greatest pandemic of my lifetime. And health professionals can use their voices to speak out about the wrongful policies and propose humane alternatives, and increasingly, as you can see, they are. Since COVID-19, PHR's list of activist members has more than doubled, and we're doing everything we can to give voice and a platform to have their voices heard. So if you aren't a member, please do sign up at our website. Another action that you can take, this session was recorded and it will be on our website shortly. So share it with those who are in a position to act and are interested in learning. And I hope you'll join us next Wednesday at 12 p.m. Eastern Time for our next conversation, which will be on the risk of mass atrocities during a pandemic, with a particular focus on Myanmar and the plight of the Rohingya. And our moderator will be Ambassador Stephen Rapp, who is a board member of PHRs. So thank you again so much. This was such a really, really good conversation, and we're so grateful to you for your time and everything you're doing in your daily lives on this issue. Thank you.
Thanks for having us.
Thank you. Bye-bye.